Good afternoon. My name is Debika Bhattacharya, and I'm an associate clinical professor of medicine at the University of California, Los Angeles, where my research is in viral hepatitis infection. I want to first start by thanking the organizers for inviting me to speak at this conference on this very important topic of an update on hepatitis B functional cure. It's really an honor. So thank you. It's a really exciting topic, especially given how fast drug development is proceeding and all of the exciting advances that are in store for us ahead. Here are my disclosures. So let's first start with the why. Why is hepatitis B disease so important? So I always start with the global burden of hepatitis B disease, which is large. Across the world, an estimated 257 million people have chronic hepatitis B disease. When looking at Thailand, the pooled prevalence across several studies is 5.1%. And of course, this burden of disease has an impact. In fact, when we look at deaths attributable to various infectious diseases tracked since 2000, you can see that deaths have started eclipsing those of HIV, malaria, and TB when talking about viral hepatitis disease. So again, emphasizing the importance of the global burden of hepatitis B disease. So you may ask, why do we need new therapies aimed at this target called hepatitis B functional cure? After all, we do have oral therapies that are very good at hepatitis B virus suppression. Well, a few reasons. First, hepatitis B surface antigen loss, this key protein that we measure, is associated with a decreased incidence of liver decompensation and hepatocellular carcinoma. It's associated with an increased survival overall and decreased levels of the latent reservoir of hepatitis B infection, otherwise known as covalently closed circular or cccDNA. And importantly, some will achieve functional cure as a natural history of their disease, indicating that such a state is possible to achieve even with novel therapeutics. And of course, when we look at the downsides of lifelong therapy, there are several. They include long-term side effects of lifelong therapy, the cost of lifelong therapy, the convenience of not having to take a pill every day, and importantly, not all available therapies will lead to surface antigen clearance or hepatitis B functional cure. So as we start talking about hepatitis B functional cure, I think it's important to remember what the barriers to cure are. And there are several, but perhaps the most important are the establishment of this viral reservoir as cccDNA, in addition to a defective immune response to hepatitis B. And so what I have here is one of my favorite schematics on the life cycle of hepatitis B, along with the various targets of the life cycle that are being targeted for hepatitis B novel drug development. And I want to make a couple of key points here. The first is when you're looking at the establishment of the latent reservoir, you can see that it occurs here after entry and nuclear transport, where cccDNA or covalently closed circular DNA is established here in these two circles in the nucleus. So it's very difficult to eradicate. In addition, it also integrates into the DNA as integrated DNA. And this is the reason why hepatitis B cannot be eradicated with currently available therapies because of this persistent reservoir. That's the first point. The second point I want to emphasize is the parallel pathways of hepatitis B production. One pathway, all from cccDNA, comes and from integrated DNA, all leads to the production of mature HBV virions or the viral load. Another pathway, though, results in the production of hepatitis B surface antigen, as well as other proteins like E antigen. And these are two separate pathways. And as you can see, if you inhibit hepatitis B virion production with a reverse transcriptase, let's say here at this point, you are not substantially impacting the production of hepatitis B surface antigen production. And that is why you can have somebody who is suppressed on nucleotide analog therapy with their HBV DNA, but they are still producing surface antigen. And this production of surface antigen is very important because we think that this surface antigen production, which is produced thousandfold in relation to the mature HBV virions, is what is leading to immune exhaustion. So again, the important parts here are from the virologic standpoint, the establishment of this latent reservoir here. But from an immunologic standpoint, there is also a defective immune response, and in large part driven by this immune exhaustion from these particles. The defective immune response lies in both HBV-specific CD8 responses, HBV-specific B-cell responses, and also innate immunity, but probably the most important are the CD8 responses. So then in thinking about novel therapies, we are going to need to have both virologic targets as well as immunologic targets. So for the rest of the talk, I'm going to be talking about various compounds. I want to emphasize that there are more than 40 compounds in phase 1 or greater clinical trial development. And a great resource is presented here, hepb.org, that details these various compounds and their stages of development. I will be focusing on a few key compounds from a few key strategic approaches, either because they represent first-in-class activity or because they have recent data from recent meetings. Okay, so before we move on to talking about the actual drugs, I think it's important to talk about the different steps that we're going to need to take on our path to hepatitis B cure. So I really think this is going to be a stepwise progression of drug development and with stepwise endpoints. So one of the first endpoints that we may achieve is the inactive state or partial cure. And in this therapy, a drug would be successful if after stopping drug, one had sustained reduction in inflammation or no inflammation with a normal ALT and liver biopsy, an undetectable or even low HBV DNA, and being surface antigen positive. So this is one potential kind of midpoint before we get to what is now the holy grail of hepatitis B drug development, which is hepatitis B functional cure or clinical resolution. In this category, a drug would result in, again, sustained off drug would result in no inflammation, normal ALT and liver biopsy, hepatitis B surface antigen loss, again, we're talking about the HBV functional cure, and ideally also hepatitis B surface antibody gain. And this right now is the holy grail of drug development. What comes next, which is I think going to be much harder to accomplish, is called complete cure, virologic cure, or some people refer to it as sterilizing cure. And that would be all of the above, plus loss of cccDNA and integrated DNA in the nucleus. And again, I think that's, we have several years before we are at that point. But these are the various different pathways on our way to hepatitis B cure. The other point I want to make about hepatitis B cure is that there are also going to be challenges in hepatitis B diagnostics. What you see here in this schema are various compartments, the nucleus, the cytoplasm, and the serum, and the various classic and novel biomarkers that we use. So the classic markers are the Dane particles or the HBV viral load that we assess, and also the hepatitis B surface antigen protein. There are also novel biomarkers like circulating HBV RNAs and hepatitis B core-related antigen, all of which we are using to try and assess the different intermediate components, including things like the subgenomic RNAs and cccDNA. Now, the important point here is that the cccDNA, or the reservoir of DNA, which also includes the integrated sequences, these are intrahepatic. There is no commercially available assessment of cccDNA. And so we have to rely currently on the assessment of biomarkers to try and predict for that. Notably, HBV DNA, as we've discussed, is suppressed on nucleotide analog therapy. So again, reinforcing the importance of looking at other biomarkers of the cccDNA reservoir. And then finally, as illustrated here with siRNA and capsid inhibitors, is that different agents are going to have different targets. And so they may impact each of these novel biomarkers and even some of the classic biomarkers differently. And so this will be an interesting and important space to watch as novel drugs are developed. Okay. So now I want to focus, we talked about having both virologic and immunologic approaches. Now I want to focus on the virologic approaches to hepatitis B in terms of novel drug development. So in terms of the virologic approaches, there are entry inhibitors, there are strategies to target the cccDNA, to target HBV RNA, packaging, DNA synthesis, and assembly and export. I'm first going to focus on targeting HBV RNA. So here, what these compounds do is they target, either by silencing RNA or by antisense oligonucleotides, they target the RNA products. And because of overlapping reading frames, which result in conserved regions, you can get silencing RNA targeting, silencing RNAs that target all HBV gene products. And so the focus here would be first on antigen reduction, so decreasing the proteins of surface antigen, polymerase, and core in order to restore immune function, as we've talked about, but also to impact the pregenomic RNA, which would subsequently block replication. So this next slide represents 3 different siRNAs that are in development. One is VIR-2218, the other is J&J 3989, and the other is the RG compound. And here, I think the 2 important points here are that all of these compounds result in between a 1 to 2 log reduction in quantitative hepatitis B surface antigen, which is an important marker of virologic activity. And also, perhaps most importantly, even when these agents are stopped, there is sustained reduction in quantitative surface antigen kind of across the board with all of these 3 agents. So again, very promising results from these 3 different agents. And this class of agents will likely be a component in a multi-mechanistic approach. The next part of the life cycle I want to talk about are the targeting of the packaging. So the core protein is essential for HBV genome packaging, for reverse transcription, for intracellular trafficking, and also the maintenance of chronic infection, because these encapsulated and only encapsulated HBV genomes are imported back into the nucleus. So there are 2 different classes of core inhibitors or capsid assembly modulators. And in one class, class 1, they produce aberrant core proteins, and these aggregates are subsequently degraded. In class 2, they produce empty capsids. In both cases, they are not producing functional nucleocapsids and should have an impact on HBV production. And so one of the capsid assembly modulators that's furthest along in development is vebicorvir. And this was a study that looked at vebicorvir plus entecavir in treatment naive or individuals who were nuke suppressed. And what you can see here is in the gray is placebo plus entecavir, and in the yellow is vebicorvir plus entecavir. And what you can see is inhibition of encapsulation with a deeper block of replication when compared to just entecavir and placebo alone. But on the right-hand side of this slide, you will see that there's very limited decline in antigen levels, core-related antigen, e antigen, and surface antigen, suggesting that this alone may not be enough. Now, why is that? Do you need a higher dose? Do you need more time? Or is this an appropriate approach to think about for intensification for those individuals who have low-level HBV viremia despite being adherent on antiviral therapy? So now let's move to targeting assembly and export. So one of the very interesting strategies has involved this use of compounds called nucleic acid polymers, or NAPs, and their primary function is to reduce hepatitis B surface antigen. And what they do is they block the assembly and release of those subviral particles that we discussed, result in this immune exhaustion with the goal of restoring an immune response. And so in this very interesting study that included one of these NAPs, two naps in combination with tenofovir and pegylated interferon in a small subset, an overall small cohort of patients, was able to demonstrate at 48 weeks 50% surface antigen loss and 56% who developed anti-HBs. And in looking at the full data set overall, there was persistent surface antigen loss in 39% of participants. So again, small numbers, but very promising data. The important update here from AASLD is that this compound is now going to be available as a subcutaneous injection. Prior, it was administered as an IV formulation, which makes feasibility somewhat more difficult. Okay, I want to shift now to host immune approaches. We've talked about virologic approaches. So under the host immune approaches, we think about three different ways to impact the immune response. One is to stimulate antiviral effector cells with TLR7 or TLR8 agonists. The other is to generate new T cells with therapeutic vaccines. And finally, we can try and rescue exhausted cells from either reducing viral antigens, modulating immune receptors with checkpoint inhibitors, or inhibiting T regulatory cells, to name a few. So now I'm going to go over a few of these strategies. So when we talk about trying to impact antiviral cells, there is the TLR8 agonist, selgantalamod, which is in development. This is a potent oral small molecule TLR8 agonist, which induces PBMC, IL-12, and IL-18, TNF alpha, and interferon gamma. And in this randomized double-blind controlled study in which participants were randomized to either placebo and tenofovir alafenamide and two different doses of selgantalamod, you can see first a very favorable safety profile. Interestingly, in the group with 3 milligrams of selgantalamide in the e antigen negative participants, there were 33% that had elevated ALT, which can be a marker of immune restoration and a beneficial immune flare, if you'd like, was interesting to note. But no patient met the overall ALT flare criteria. And then looking at the virologic changes, there were sustained declines of at least a half a log of quantitative surface antigen from baseline in patients treated with selgantalamod. So again, a promising approach, again, probably needs to be done as a multi-mechanistic approach. And I think there's an important cohort also to evaluate this in, and that's in those living with HIV and hepatitis B, because a TLR8 agonist may also have activity against HIV. And indeed, the AIDS Clinical Trials Group, or ACTG, does have a trial of selgantalamod in HIV Hep B co-infection in development. So something to look out for. Next, let's move to therapeutic vaccines. So the goal here is to restore a diminished T cell response. Initial studies had early limited efficacy. And one of the reasons that's been hypothesized is that the T cell exhaustion that results from chronic hepatitis B from this high viral antigen load that we've discussed may need to be reversed first. And in fact, there are potential combinations of therapeutic vaccination plus a compound that inhibits surface antigen, i.e. an siRNA, and then another one that also boosts the immune system like PD-1. And so these will be important studies to follow. I do want to highlight one vaccine, the NASVAC vaccine, that was presented a few years ago at AASLD, and this contains both surface antigen and core antigen. It is administered biweekly intranasally, and we're beginning to learn about the importance of intranasal administration of vaccines here, particularly with SARS-CoV-2. And in this study that involved both nucleotide analog suppressed and inactive carriers, we saw that 3/4 had a 20% decline in their quantitative hepatitis B surface antigen. 1/3 of participants developed an anti-HBs, and 2 participants in each group lost surface antigen. So again, very promising preliminary results, again, will likely be used as part of a multi-mechanistic approach, but another tool in the overall armamentarium. Finally, I want to move to the part of the immune control strategy that involves rescuing exhausted T cells. So one arm here is looking at PD-1 inhibition. So chronic HBV is associated with a highly attenuated CTL response. And in fact, immune checkpoint inhibitors could reawaken vigorous T-cell immune responses. We know in cancer trials that they have revolutionized therapy by reversing T-cell exhaustion in some malignancies. And so this is where we're drawing from. And in fact, PD-1 is one of the most relevant checkpoint inhibitors for hepatitis B because it is expressed on HBV-specific T cells, and the ligand for PD-1 or PD-L1 is on liver cells during hepatitis. This was kind of elegantly described in a proof of concept study in hepatitis B monoinfected participants who received nivolumab. And here you can see the dramatic quant S decline in at least one participant receiving nivolumab. But importantly, that one participant cleared surface antigen and was able to stop tenofovir 4 weeks after dosing. More than a year later, this person remained surface antigen negative and anti-HBs positive. So it's a very interesting proof of concept. It was a low dose that was given. But as you can see here in the pink, this is the ALT flare, but there was a pretty big flare. And I think this highlights again the importance of distinguishing a beneficial flare that is resulting in immune restoration versus a potential detrimental flare from an immune checkpoint inhibitor, but also from other drugs where the concern for drug-induced liver injury is also there for novel drug development. So this will be an important space to watch in terms of how this is managed. So this brings me to another study that the ACTG is doing, 5368 or Check HBV, which will be examining in a multiple dose ascending study another FDA-approved PD-1 inhibitor, cemiplimab, in HBV monoinfected participants. They'll be receiving 3 different doses, 0.3 milligrams, 1.0, and 3.0 milligrams per kilogram of cemiplimab in 2 infusions. And this is a small study of 30 participants, but in those participants who undergo a liver biopsy and fine needle aspirate, we're really very excited to be looking at some of the translational science here. So looking at the quantification of intrahepatic cccDNA, CTL responses, gene expression changes, and then also some changes in fibrosis. So another very kind of promising study to put on your radar that should be opening soon as well in Thailand. And so as we kind of talk about attractive combinations, then we're really talking about different mechanisms. So one would involve HBV DNA suppression, which can be accomplished with ongoing nucleotide analog therapy, but potentially also with capsid assembly modulators, RNA inhibitors, CCC DNA inhibitors, which we haven't described because they're in preclinical development, but are promising. Also, viral protein depletion is going to be important. So this is where we reduce the overall antigen load with, again, RNA inhibitors, the NAPs, as we've discussed, and then again, also CCC DNA inhibitors. And then finally, combining that with an immune target with TLR agonists, PD-1, PD-L1 approaches, or a therapeutic vaccine. This is going to be a very complicated and interesting matrix where there'll be lots of mix and match approaches. And so it'll be very important to, as these drug trials develop, to see which of these combinations is going to be the most successful. I do want to highlight a couple of these combination therapy approaches. The first combination therapy approach that was presented again at AASLD recently was a combination of an siRNA and a capsid assembly modulator, J&J 3989 and J&J 6379. And in this study, what they did is they allocated participants to placebo, one arm of the J&J 6379, the capsid assembly modulator, and then 3 different doses of the siRNA, and then finally a combination arm here in the green. And I think one really important thing that this study did is it started defining a primary endpoint, which is looking at nucleotide analog stopping criteria, because this is really going to be one of the most important things that we're looking for in hepatitis B novel drug development. And here they defined it as having a low ALT and undetectable HBV DNA being e antigen negative, and having a surface antigen, quantitative surface antigen less than 10 IUs per ml, all at the end of treatment. And when you looked at these different arms at the end of treatment and in follow-up, you can see that the highest dose of the siRNA resulted in 19% of individuals meeting the nucleotide analog stopping criteria. And in fact, in that same highest siRNA dose, 75% of individuals achieved a hepatitis B, quantitative hepatitis B surface antigen level of less than 100. But what was interesting is that the combination therapy, however, of the siRNA and the capsid assembly modulator did not result in an additive response. And the reasons for this, I think we're going to be teasing out for several months to come. But I think important to note that, at least in this combination, it did not show the impact that we were looking for. So again, it'll be very important to watch over the next several months. Another combination therapy to highlight is that of another siRNA, VIR-2218, and pegylated interferon. In this study, participants were allocated to different strategies, which involved in 3 arms the addition of pegylated interferon, 2 of which the pegylated interferon was initiated concurrently with the siRNA. And in this study, in these 4 different arms, the majority of participants, 92%, who had completed the week 24 visit, achieved a quantitative surface antigen of less than 100. And interestingly, those participants who were concurrently initiated with the pegylated interferon and the siRNA achieved, more of those participants achieved surface antigen of less than 10 compared to those receiving just the VIR-2218 alone. 3 participants here achieved an undetectable quantitative surface antigen. So again, another exciting space to watch. And pegylated interferon is something that at least many of us are a lot more familiar with than some of the other immune modulators. So very exciting results here. So one of the last slides I'll leave you with is the fact that all stages of hepatitis B disease are not the same. And so in this classic depiction of the stages of hepatitis B disease, in those individuals who are infected perinatally, there are several phases: the immunotolerant phase, immunoactive phase, a low replicative phase, and a high replicative phase. And each of these different stages, as people progress through these stages, may require different strategies. They may require different combinations of these novel agents, and they may also require different durations of therapy and different endpoints. And in fact, as we've mentioned earlier, different agents may require different biomarkers. In addition, when we think about the very important subcohort of people living with HIV, there are going to be things like drug-drug interactions to take into account, as well as whether or not hepatitis B therapy can be safely stopped in those persons living with HIV, for whom the risk of flare is also an issue. And so I think there's a lot of work to be done. I hope that many of you in the audience are excited by the work that's coming down the pike and will start to get involved in a lot of this upcoming research. So in summary, novel therapies aimed at HBV functional cure are going to be necessary because of the global burden of disease, and because without hepatitis B surface antigen loss, we really do not achieve the endpoints that we're looking for. And because surface antigen loss is associated with such improvements in things like the incidence of hepatocellular carcinoma and survival. We will also likely need a multi-mechanistic approach. As I've mentioned a couple of times, the etiology of hepatotoxicity will be important in determining whether the hepatotoxicity is because of a beneficial immune flare or whether it's a result of drug-induced liver injury, or in the sphere of immune checkpoint inhibitors, whether that also represents an autoimmune disease. That determining that etiology of hepatotoxicity is going to be very important. And then finally, the fact that these stages are not created equal. There are going to be different treatment strategies, different duration, and different endpoints, and surrogate biomarkers, again, from all in different populations. And in fact, again, this may very well be a stepwise approach where we get to a point where we allow 50% of people to still be surface antigen positive and call that a win while we work on developing those therapies that really result in full Hep B functional cure. And so with that, I will end and thank you again to the organizers for extending the invitation, and also to my colleagues and participants within the AIDS clinical trials group and within the hepatitis transformative science group, or TSG. It's a remarkable group of individuals that is now turning their focus to drug development and clinical therapeutics in hepatitis B, including in hepatitis B monoinfection, and really just an extraordinary group of individuals. So with that, I say thank you.